let's go ahead. Now, we're gonna start, we'll start with the didactic stuff at the end. If you have questions, I'm happy to answer any questions, especially with that title slide. Now you shouldn't be afraid to ask. You can ask and I'm happily will answer. So first thing we wanna do is, what is spirometry? Now, I want you all to do this. I'm gonna coach you right now, okay? So we're all gonna do a spirometry sitting here. So what we're gonna do before we do it is you're gonna take a deep breath in and then you're gonna blast the air out, like really, like push it out. Not a half-hearted blow, but a real push. And then you keep going and going and going. You do it you're trying to do 6 seconds, or if you can't reach 6 seconds, there's like a 1 second, like if you can't push out any more volume and you've reached a 1 second plateau, that counts as good enough by American Thoracic Society standards. Then you take a deep breath in, and then you have to repeat it. So we're gonna do this now, just humor me, okay? Because you will see what this feels like. And I remember as a pulmonary fellow, they had me do PFTs on myself. And you have to pay a lot of attention. You have to push really hard. You feel like you are getting blood from a stone, like you feel like your lungs are concrete. And we're asking our patients to do this. And you know, we're hopefully pretty hale and hearty, and at that point I was young. But we're asking our patients who may not feel well or may be older to do this. So, okay, so now we're all together now. Deep breath in. Blast! Oh. Keep blowing. 2, 3, 4, 5, 6. Now inhale, deep breath in. That is spirometry. Now you have to repeat it at least 2 times to make it reproducible. So first, is it an adequate maneuver? So now you know what it feels like. And if you haven't done it before, it's like, oh, oh, I get it. It's hard. It's hard. And you feel like you're exhaling with nothing left, but someone's still yelling at you to blow, 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 blow. So that gives you an idea of what we're asking our patients to do. So next, we're going to talk about, this is what we get. On the left is a flow volume loop, and you can see flow on the y-axis, volume on the x-axis, and then on the right is the flow time loop. And you can see that you're trying to blow out for 6 seconds. I don't know, do we have a laser pointer? Oh, a cursor, okay. Oh, here we go. Yeah. All right. So this is the flow time loop, and you can see that this is the volume, this is the time, and you can see most of your air comes out, a lot of it comes out in this first second, right? So this is 1 second, 2 second, 3, 4, 5, 6. So this is the FEV1, the forced expiratory volume in 1 second. And then remember when you were pushing and pushing and you felt like you were exhaling almost nothing? That's this portion. And remember, we're trying to get to 6 seconds, that's great. But if someone can't get to 6 seconds, sometimes if you have a 1 second plateau, say we're over here, and they can't push out any more volume, then that counts too as a valid effort. Okay, so there are a lot of snafus that we see. And first, what's an acceptable? You have to have a good start. So when I said blow, I wanted you to blow, like immediately. I didn't want you to say, oh, she said blow, let me blow now. You know, you have to really blow immediately. You have to have that satisfactory exhalation where you're really pushing out hard, but you're also pushing out long, at least 6 seconds or the 1 second plateau. And it has to be free from artifacts. Sometimes people blow and they, that's not acceptable. Or sometimes they close their glottis, so they're blowing, and then you feel the glottis close and suddenly no air comes out. Or they stop early, and we see that all the time, and I'll show you some examples of that. Sometimes there's leak, like you have to have this thing in your mouth, and you can't have it leaking out the sides. So if there's leak around the mouthpiece, you're not going to get a valid maneuver. And sometimes the mouthpiece can be obstructed, like they put their tongue in there, or their teeth in there, or their dentures kind of slide out and obstruct them out. We've seen everything. So you have to make sure that it's a good effort, the air is coming out through the mouthpiece, not around the side, and nothing's obstructing the mouthpiece. And then submaximal effort. Like if you think about the patients, you know, who may do PFTs on, like, for example, in the PFT lab, I may get an 18-year-old, well, at Michigan, I get like 18-year-old with arthritis, like strapped guys, and, you know, they could do a lot. And then I get like a 95-year-old granny who is on her third malignancy and really isn't feeling well, and, you know, may not be able to do the test just because she. So these are some potential pitfalls. This is just the expiratory limb of the flow volume loop. So actually, this was the best slide with all of them I found, but I didn't like this normal. I would say the peak should really be closer over here, but I guess it's okay. Here's one where they blow and then they, and sometimes you see blow and kind of thing. Here's a glottic closure where they blow, and they're blowing, and then suddenly they stop. Their glottis closes, they can't get more air out. This is the suboptimal effort where, for a variety of different reasons, they're just not doing the big, blast, they're not doing the sustained effort, they're not reaching, like here you have just this high peak. Here, I call this the soft top. You're not getting this big peak, and it's also just lower down. And here's someone who hesitated. It's got a decent looking shape, but you can see that they're like, what do I do? What am I doing here? And then they blow. So you can see all these things happen. So then let's look at the flow time loop. So we talked about the flow volume loop. This is the flow time loop. So again, this is the volume, the exhaled volume. This is the time on the x-axis. So this is someone who stops early. Remember, we're trying to do the 6-second maneuver or the 1-second plateau, and they blew out 1 second. So is this a valid maneuver? No. Then you have someone with, this is basically kind of the slow start. It's the excessive extrapolated volume. So instead of starting here where the dashed line is supposed to be, they kind of have a hesitation and they start over here, so that's a delay. Sometimes they do this funny, like, sometimes they're blowing out kind of like a wave, and they do this sort of extra breathing over here. That's, you know, you want the volume, the exhale volume to keep increasing, not go down and then go up. And then here's someone who this one is a delayed start because they just had a weak blast. So you're like, blow, and then they're like, low. So you can see all these sort of funky patterns that happen. Now, what is reproducibility criteria? When my husband was in grade school, or middle school, he said, A was awful, B was bad, C was carefree, D was delightful, E was exceptional, and F was fantastic. In this case, it's not the same for our reproducibility criteria. Here we are trying to achieve A's, and what you get is, for an A, remember I said you have to do the maneuver a minimum of 3 times, so that's why you have at least 3 acceptable maneuvers. And you have to have repeatability within 0.15 liters. And then for B, you have 2 acceptable maneuvers, and again, 0.15 liters. C is greater than 2 acceptable, but then the repeatability is a little less stringent. You can see for D, again, less stringent. And then what we're shooting for at the very minimum, I mean, we're in medicine, we're all going for A's. But A's and B's are what we're really trying to shoot for. C, I mean, when you get to D, E, and F, I think those are pretty unacceptable results, and you can't draw a lot of information. Because the thing about spirometry is it's a piece of information. It's not what you hang your hat on. It is one piece of information you get in conjunction with the history and the physical and the other findings, the echo and the chest x-ray, et cetera, et cetera. It is one piece of information. But it's important, if you have a piece of information, that you trust that piece of information. And that's where all of this comes in. And this is the 2019 standard, which is a little more stringent than the original not original, but the older 2005 standard, where you have different repeatability criteria. And sometimes people find, I think some of the World Trade Center people have found that it's easier to achieve good grades using the 2005 standard than the 2019 standard. And I have a theory about that. But anyway, so you can see that you have, again, you're trying to get more than 3 acceptable measurements, and the difference between the best 2 FEV1 and FVC values is less than 0.1 liters, and it goes on from there. And again, we're trying to get A's, and A's and B's are good, and the rest of it is, you really have to be careful what you conclude from a test that has C's on down. All right, so how do we interpret? Okay, so we always look at the loop, right? And yes, and this is a more normal flow volume loop. So you can see a big push out, blow, 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 inhale. And that's a normal flow volume loop. Now, people with a restrictive impairment may have a narrow loop, so their loop looks squashed. So they may not get as much volume out, or as much volume out, or as much flow, but it's kind of proportional, as opposed to an obstructive pattern where you get the classic scooped out expiratory limb. Now, I'm going to say that we don't use the loop to determine whether someone's obstructed or restricted. You do numbers, period. And yes, a lot of restricted patients with restriction look like this. A lot of patients with obstruction look like this, but it can fool the eye. Now, the real reason that I look at the loop is, one, when I'm reading someone's PFTs, I look at the demographics, because I'm reading these PFTs cold. So I look at the demographics, then I look at the flow volume loop and the flow time, and I get a sense, and I look at the grades that I get, and I say, is this adequate or not? That's the first thing I do. Then I will look at the shape of the loop, not for obstruction or restriction, but to determine whether there's a fixed airway obstruction, a variable extrathoracic airway obstruction, or a variable intrathoracic airway obstruction. So a fixed airway obstruction, actually, I would draw this. There's flow limitation both on exhalation and on inhalation, and it tends to be actually a little more squared off than what this picture is showing you. But this is something like a tracheal stenosis. Then you can have a variable extrathoracic airway obstruction where it's some obstruction outside of the chest. So, exhalation can be normal, but inhalation may be flow limited. So I've seen this with like a goiter. I once saw a patient whose goiter was getting bigger and bigger and bigger, and had been lost to follow up, and then came for a PFT, and I'm like, whoa, this is really bad. So we contacted her PCP, and the patient actually, I think, was going to have surgery as a result of the PFT. So it was actually a very useful thing. And a variable intrathoracic airway obstruction is something is inside the chest, like say you have something in this part of the trachea that kind of flops around. But we don't see this all that often. All right, so don't use the appearance for interpretation. You can say, maybe there's a fixed airway obstruction, and whenever you say fixed airway obstruction, variable extrathoracic obstruction, or variable intrathoracic airway obstruction, we always say clinical correlation is recommended. Okay, but now we're going to really focus on sort of this, and this. So don't use the appearance for interpretation. The story is in the numbers. So where do we get our predicted values? So predicted values, there's a long, interesting history of what's considered normal for PFTs, and what's considered normal for a lot of different tests that we do in medicine. So predicted values are based on age for PFTs, age, height, and sex at birth. And the predicted values, some of the old predicted sets, like some of the ones when I first started interpreting PFTs, predicted sets were from the 70s, and they skewed very Caucasian. And then for a while, for a long time, people were using race in the predicted sets, and ATS a few years ago just came out with a statement that we should not be doing that. So race is no longer part of the equation. And then we have sex at birth. Right now, no one has addressed what do we do with people who started taking hormones before puberty. That's the Wild West. I don't know where we go from there, but that's just sort of an interesting question to think about in future. But right now we have age, height, and sex at birth. Now, what if you don't have height? What if you have someone who's like completely scoliotic, or someone who's in a wheelchair and can't stand? What can you use as a surrogate for height? Arm span, wingspan. So that's something that you can use. And then, so I talked about our old data sets that came from the 70s, and you're gonna remember all of those. Now we use data from, now we use data from something called the GLI, which is called the Global Lung Function Initiative. I don't know why it's not called the GLFI, but it's called the GLI. And that is a much more robust data set. The old data sets tended to have a lot of middle-aged adults and didn't have a lot of data for older adults, didn't have a lot of data for young kids. So the GLI is a much broader age range. I think it goes from 3 to 95. So it's a much broader age range, and it's much more worldly. So we have more data from more parts of the world. So now the GLI, we use our predicted values. We use something called GLI mixed or GLI global, which takes data from all over the world. It still tends to skew more Caucasian, but it's much better than the old data sets we used to use. But that's what we're using right now. And they're constantly trying to add to the GLI database. Yes?
Sometimes weight doesn't
weight, weight can have effect on PFTs, but should not determine what is normal. So sometimes with obesity, you can see changes, like you can see decreased DRV, decreased FRC, but should not determine normal for that person. So I always, when I'm reading a PFT, I look at the demographics. I look at age, height, sex at birth, weight, to give me just a sense of why I'm going to see some of the things that I may be seeing. And then of course I look at, who's the ordering doc? Like if I see Maria Padilla, I know it's likely going to be interstitial lung disease. And I look at the symptoms. Is it dyspnea? Is it wheezing? Is it, whatever? But these are patients that you are seeing yourself, so you know everything about them, as opposed to me sitting in my office where all I get is the little banner at the top of the screen. Sometimes when something's really interesting, I'll go into my chart and do a deep dive. Like if I see a really funky looking loop that looks like a fixed airway obstruction, I'll go into my chart and I'll say, oh, they're seeing ENT for tracheal stenosis. Okay, I got that one right. So you have a lot more information than when you're looking at spirometry. All right, so this is a normalized distribution, okay? So everything in life is kind of like this, weight, height, lots of other things that we measure. So it's got this nice bell-shaped curve. And at the bottom, you have the bottom 5th percentile, and at the top, you have the top 5th percentile. And most people, though, are squarely somewhere in here. So then the z-score is basically standard deviation. The z-score is the same as standard deviation. It's how many standard deviations you are away from the mean. So a z-score of -1, you're 1 standard deviation away from the mean. 2, you're 2 standard deviations of the mean away from the mean. So there's nothing really magical about it. And a z-score of -1.65 is also the 5th percentile. So this is also the lower limit of normal. So that's why you have a 1.65. So, and you guys have z-scores. Do you guys have z-scores on your reports? Okay, yeah, okay. It's funny, it took me so many years to get z-scores when I was at the University of Michigan. It took me almost a decade I actually never managed to do it because it requires new software. So I had tried for years and years and years to get it. And finally, after I left, they got all the, so I felt like I'd done something. And I came to Mount Sinai, I'm like, oh, no z-scores. But it's only taken me, I think, 2 years to get the z-scores, so that was much easier. So let's start with a thing that you see a lot of. So you have a sense of what's normal. All right, obstruction. So obstruction has one definition. It is an FEV1, forced expiratory volume, over FVC, forced vital capacity, below the lower limit of normal, which is the 5th percentile, or a z-score that should be minus 1.65, got cut off. So that's obstruction. Now, so the FEV1 to FVC tells you obstruction, yes, no, all right? There is one caveat that I'll go into in a second. Then you look for severity of obstruction is based on z-score. So, so if your z-score is between minus 1.65 and minus 2.5, you have mild obstruction. If your z-score is between minus 2.5 and minus 4, it's moderate obstruction. And if it's less than minus 4, then you have you have severe obstruction. So obstruction, yes, no, based on the ratio, and severity of obstruction based on the z-score. Now, what if you have a decreased FEV1 to FVC and your z-score, oh, I'm sorry, the z-score is based on the FEV1. So the obstruction, yes, no, based on the ratio, and then you use the FEV1 to determine the severity. What if you have obstruction, a reduced FEV1 to FVC, but your z-score is 1.60? That's actually something called dysynapsis, which I don't quite know if I believe, but it's supposed to be a developmental thing, that the size of the airways and the size of the lungs are not necessarily proportional. I don't quite know what to make of it, and it seems, I mean, this term has been around for a long time, but it just sort of seems like something a statistician would use to justify the numbers not falling into place, but sometimes things don't quite add up. So on occasion, you can see stuff like that. And so this would be considered normal or dysynapsis. But anyway, I see that a fair amount when I'm reading. I don't know how often you see it, but now you know kind of to look for it. But a lot of times I'll see people with COPD and they end up having criteria for dysynapsis. I'm like, looks like obstruction to me. Or sometimes I'll see people with like a known history of asthma, and it just happens to be that's the way they did the test that day. Yes?
Might you see that in individuals who have a history of being born prematurely?
Yeah, that's probably where it really comes from, but it's just kind of hard to I don't know that there's necessarily a way to study airway size versus lung size or parenchymal size. So I think it's hard to prove, but in theory, yeah, that would be probably a very good reason for it.
But if you see the dysynapsis, like what can you do? Because you can't really change the size of their airways.
Well, that's the thing is, like, how much do I believe it? And I'm not completely convinced, because I see people who have emphysema, who end up meeting the criteria for dysynapsis. I'm like, but again, PFTs are spirometry, one piece of information. It does not discount all the other stuff you see. So if I see dysynapsis one day, but I know the person has emphysema on a CT scan, I'm not gonna say, oh my gosh, they don't really meet criteria for obstruction. It's just one other piece of information. Sometimes the things don't add up in a nice, neat little package, and these are some of the things that you can kind of fall into, but this is a piece of information, not the piece of information. But I get frustrated with that. All right, now restriction. Okay, never ever call restriction based on spirometry alone. So a low FVC may be suggestive of restriction, and you might see that squashed little loop, but you always have to have lung volumes, TLC, to confirm. Never call restriction based on spirometry alone, or this is the sign of, I will hunt you down and find you, if you do. Actually, my eyes are a different color, but otherwise that's me. So you can say, like if you're reading a PFT, you can say reduced FEV1, reduced FVC, normal FEV1 to FVC ratio. Spirometry is suggestive of restriction. However, TLC is required to confirm this finding. So you can say suggestive of, but you can't say restriction ever. So what's a positive bronchodilator response? Because I know you guys do that. So it's actually pretty easy. It's an increase in the FEV1 or the FVC. Doesn't have to be both, can be one or the other, greater than 10% of the predicted value. And you should see that typically in the right-hand column. You'll see a plus, a plus minus, whatever. It has to be greater than 10%. Can be either, can be both. Some people have a negative response to a bronchodilator, and that may not, some people, on rare occasions, you can have bronchoconstriction with that, but a lot of times people are just getting tired. You've already had them do spirometry a whole bunch of times, then you give them a bronchodilator, and you're having them do that a whole bunch of times, like at least 3 times to see if this is an acceptable, a reportable maneuver. And sometimes they just get tired. So a lot of PFTs, I would say, is in the coaching, and it's a little bit of an art to getting a good response from a patient. And as my PFT lab manager, she says, some people are just uncoachable. She can get PFTs from anybody, really can get PFTs from anybody. And she's like the greatest coach I've ever met. But sometimes even she can't get a good PFT from someone because sometimes they just can't do it. So anyway, so sometimes these people are just getting tired, or sometimes they have a decrease with the bronchodilator, but it doesn't necessarily mean anything. So don't read a huge amount into the decrease. Unless someone says, the second I got albuterol, my chest felt tight, I started wheezing, I felt horrible. Okay, I buy that one. All right, so the best thing about reading PFTs or reading spirometry is doing examples. And you only get good when you do a lot of them. Like after your first 50, you start feeling comfortable. After your first 1,000, you start getting, getting the hang of it. But the more you do it, the better you get. And I always do things the same way every single time, because that way I always have a method. Always have a method, and I never deviate. So I always catch things. And I would encourage you to do it the same way every single time. You find the way that you like to do it the same way every time. And just sort of, I have check boxes kind of in my head. All right, so case number 1. Okay, take a deep breath. I'm not gonna make you blow. There's a lot of information over here. Let's just go step by step. All right, so I'm gonna give you what I see. So, of course, I cut out the name, but this is a male. He is 64 years old. His height is 68.9 inches. His BMI is 26, so he's overweight. This is the ordering provider. Sometimes I just look to see who ordered the test, and it just gives me a little bit of a hint. And then I go. So I start up here, and then I go to the flow volume loop and the flow time loop. And he did a nice blow with a pretty good sharp peak. He inhaled, but here's a question, something to point out. This does not match this, right? So why do you think that is? Well, he blew out a lot, but he didn't suck in very much. And so that's why these things don't match. And then on the usually, you should see, next time I do a normal, I'll pick a better one, but you should see this, and then normal inhalation should be like this and go all the way back to the 0. But let's pretend it's that way. Next time I'll get you a better example. And this is the flow time loop where at time 0, he starts to blow and he's got a big peak. And then this line is right where his FEV1 is. and then he keeps blowing, 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 blowing. He gets to 6 seconds, mazel tov, and he keeps going, so good for him. All right, so good maneuver, and you can see he's got, these are the grades we get, the FVC. This is the 2019 criteria. He gets an A for the FVC, he gets an A for the FEV1, so great. All right, so we have good data, except for the inhalation, and we're gonna go ahead and we're gonna say, okay, this looks good, we're gonna go ahead and interpret it. All right, so I like to start with the ratio first. And to orient you, this is, you guys may have, your reports may look a little different, but this is baseline, this is what he is doing on his value. This is the lower limit of normal, this is the upper limit of normal, and this is the Z-score, okay? So his ratio, lower limit of normal, now this was interesting. Back in the old days, you remember, we used to use an FEV1 to FVC of 70% as an all-purpose cutoff. And that was okay back in the 90s when I started doing this. So if you think about, typical adult ratio of 70%, maybe totally fine. But in a strapping University of Michigan football player, that ratio may actually be low, and their normal ratio should be about 75, 76. And in a little old granny who's like this tall and 95 years old, her lower limit of normal may be like 62, 63. So the all-purpose cutoff overestimated obstruction in some groups and underestimated obstruction in some groups. And so when we went to the lower limit of normal, it was a much more robust measurement rather than the all-purpose cutoff. So, so in this case, our ratio is 86%, and which is normal. Okay, so then we look at the FEV1 and we look at the FVC, and he's got on FEV1, which is actually, I should have picked a better example, but his FEV1 is slightly reduced. The lower limit of normal is 2.30, his baseline is 2.28. So that's a little bit low, and you can see his Z-score is less than minus 1.65, so that's a little bit low. And this is just a graphical representation. This is the predicted, these are the Z-scores, so you can just, for people who like graphs. And then the FVC of his lower limit of normal is, his baseline value is 2.65, and his lower limit of normal is 3.03. So this is reduced. So normal ratio, but reduced FVC, reduced FEV1. So no, do we have obstruction? No. Could we have restriction? Maybe. Are we going to call it here? No. So I would say this spirometry, normal FVC, normal ratio, reduced FEV1, reduced FVC, suggestive of restriction, need lung volumes to confirm this finding. Okay. Case number 2. All right. So this is a 51-year-old male, diagnosis of asthma, BMI 32. His height is 65 inches. This is Udit Chadha, who's one of our interventional pulmonologists. So whenever I see Udit's name or Tim Harkin's name, I know there's going to be trouble because they never see patients who are healthy. So then I look at the flow volume loop and the flow time loop. And does it look like a good effort? Yeah. Does it look like a funky loop? Absolutely. It looks really kind of scooped. Are we going to call obstruction based on this? No, but we don't have a variable intrathoracic, extrathoracic, or fixed airway obstruction. And then you can see the pre is the blue line. It's with the box. Here it's the blue line. And the post is the red line with the triangle. And what's interesting when we look at the flow time loop is, yeah, they hit 6 seconds on the pre, but they are still exhaling at almost 12 seconds. So we see that a lot in people with obstruction. We see that very commonly. All right, so we've kind of primed the pump. We know that it's, 51-year-old asthma, Udit Chadha patient, trouble, loop that looks obstructed, and it takes a long time to get their air out. But let's go to the numbers to find out what's really going on. Oh, and then of course we look at the grades and we get A's, both for baseline and post bronchodilator. So let's start here. baseline values. Here's our lower limit of normal, upper limit of normal, and z-score. So we start with the ratio. FEV1 to FVC, 54%. What do you think? Low, right? And then we go to the FEV1, also low. And then we go to the FVC, which is normal. All right. And then we look at the severity of obstruction based on the FEV1. So this is a, now I'm blanking. Is this moderate? It's moderate. Yeah, it's greater than 2.5. So this is a moderate. So we have a moderate obstructive ventilatory impairment. Now we look for bronchodilator response. We get a percent change of 14% on the FVC, only 4% on the FEV1. Do we have a positive bronchodilator response?
Yes.
Yes, absolutely. We only need one of these to be 10% or more, and we hit it with the FVC. We don't have to have both. All right. And you can see, on the flow time loop, you can see that he blows out. He has more volume on exhalation with the bronchodilator. Okay. So this is a moderate obstructive ventilatory impairment, positive bronchodilator response. Okay. Let's go to the next one. Case 3. All right. So this is a 63-year-old female, 63 inches, Maria Padilla. So I know what kind of patients Maria Padilla sees. She does a lot of interstitial lung disease. Then I look at the flow time loop and the flow volume loop. So the flow volume loop looks squashed, right? Could there be restriction? I don't know. We'll take a look and see if we think maybe there's a hint. And then look at her flow time loop. Does she get to 6 seconds? No. But she does have a 1 second plateau where she can't blow out anymore. So is this an adequate maneuver? Yep. And then if we look at her grades, she gets an A both on the FVC and the FEV1. All right, now let's go to our numbers. FEV1 to FVC, lower limit of normal is 67, upper limit of normal is 90. She's got a ratio of 90. So that is something that I often see in patients with restriction. FEV1 is reduced, right? Lower limit of normal is 1.57, FEV1 is 1.09. The FVC is also reduced, 1.22, lower limit of normal is 2. Now, do we call restriction based on this? No, I will hunt you down, but it is certainly suggestive of restriction. So I would say that normal ratio, because the upper limit of normal is still normal, normal ratio, reduced FEV1, reduced FVC, suggestive of restriction, need lung volumes to confirm this finding. But I think I might have just taken this from a full PFT, so I know what her lung volumes were, and she ended up having a low total lung capacity. All right. Case number 4, different animal. All right, this is a 62-year-old male, shortness of breath, height is 68.5 inches, BMI is 24. Joe is the ordering physician. Oh, the other thing that's fun to look at is the predicted modules. Remember how I said we use the GLI global? Here it is right here. So in this one, I didn't include the flow time loop, but what do you think of this flow volume loop? This looks different than anything else you've seen. What does it look like? It looks like you have flow limitation on exhalation, flow limitation on inhalation. That's clearly abnormal. And what are the diagnoses that you can posit based on the visual inspection of the loop? A fixed airway obstruction, variable intrathoracic or variable extrathoracic. And this looks like a fixed airway obstruction. So let's go to the numbers anyway. I mean, we always go to the numbers, but FEV1 to FVC, lower limit of normal 65, the ratio is at 65. The FEV1 is reduced, the FVC is normal. So it does not meet the criteria for your typical obstruction over here, but this is clearly abnormal. And I can tell you when I did a deep dive in my chart, sorry, that's what we used to call it at Michigan. We used to call it MI chart, here instead of MY chart, and we called EPIC my chart. Anyway, when I did a deep dive in EPIC, I found he had tracheal stenosis. So whenever I see something like this, I always, I always like confirm to see, is this something I'm seeing? If it's something new, then of course I point it out to the referring doc, and yes.
Can a large thyroid gland cause this?
It could cause usually a variable extrathoracic, unless the thyroid is extending down into the chest, because there's the part it's like what's above and what's below, and that affects all the pressure volume relationships. But usually a thyroid is going to be an extrathoracic. But yeah, I've seen that before. And that's what I have for you on PFTs or spirometry.